We're now going to talk about scleroderma, or systemic sclerosis. The cause of scleroderma is unknown. Scleroderma is diffuse in 20% of patients and limited in 80%. Limited scleroderma is known as CREST syndrome. It stands for calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. So how do you answer the question, what is the most likely diagnosis? Well, look for a young woman in the 20s to 40s category. Women are 3 times more affected than men. They're going to present with fibrosis of the skin and internal organs, such as the lung, kidney, and GI tract. Raynaud's syndrome is increased vascular reactivity of the fingers, beginning with pain, then pallor, cyanosis, followed by reactive hyperemia. So it goes from white to blue to red. It's pretty patriotic. Raynaud's is precipitated by cold and emotional stress. Some cases can actually lead to ulceration and gangrene of the fingertips. Some skin manifestations of scleroderma are fibrosis of the hands, face, neck, and extremities. Telangiectasias can occur anywhere, and you can also have abnormalities of pigmentation.
Well, at least within the last 2 years. I mean, I had tightness that I noticed, but I think it got worse within the last 2 years.
Okay. So you noticed some skin changes in your face just recently?
Well, 2 years.
Okay. What did you notice?
Tight. Look different. I don't look the same anymore.
But my earlobes disappeared. I used to have earlobes that came down a little bit and I could put an earring on them. Now they're gone. I could still put the earrings on, but the earlobes are gone.
Can't make a fist?
No,
And what happens when you try?
I can't.
Okay,
Can't
that's as far
close
as you can
them.
go?
Yeah, it's as far as they'll go.
Okay.
And it seems the right hand is almost worse than the left. And when I straighten it out, I can't straighten it out.
That's as far as you can open it?
Yeah.
Okay, and go ahead and try to make a fist. And what do you feel stopping you?
They just don't bend any further.
Just try to squeeze the skin on the back of your fingers. So it's pretty tightly bound
Yeah.
down.
Here's a patient with scleroderma. Notice the extreme fibrosis of the skin on the dorsum of the hands. There is multiple organ involvement with scleroderma. In the GI system, you can have esophageal dysmotility and GERD. You can even have diverticuli of the small and large bowel. In the renal system, you can have sudden hypertensive crises. In the lung, you can have fibrosis that leads to restrictive lung disease that can lead to pulmonary hypertension from lack of compliance. From a cardiac standpoint, you can have myocardial fibrosis, pericarditis, even heart block. And the lung disease we just mentioned can give right ventricular hypertrophy. When testing for patients with scleroderma, an ANA will be positive in 85 to 90% of people, but as we already learned during lupus, this is nonspecific. An ESR is surprisingly normal. An SCL70 antibody is the most specific test. This is the anti-topoisomerase, but is present in only 30% of those with diffuse disease and 20% of those with limited disease. The anti-centromere antibody is present in half of those with CREST syndrome. Anti-centromere antibodies are extremely specific for CREST syndrome, so if you see it, click CREST and move on. No treatment can stop the underlying disease process of scleroderma. Penicillamine is not effective. For the renal crises, ACE inhibitors are preferred. You can even use them if the creatinine is elevated. For esophageal dysmotility, you give PPIs for the GERD. To prevent Raynaud's phenomenon, you try calcium channel blockers. For the pulmonary fibrosis, we use cyclophosphamide. This can improve dyspnea and raises your PFTs. Pulmonary hypertension is treated like primary pulmonary hypertension with bosentan, which is an endothelin antagonist, or sildenafil. We're now going to move to the myositis, polymyositis and dermatomyositis. These inflammatory myopathies present with proximal muscle weakness, leading to difficulty getting up from a seated position or walking up a flight of stairs. They do not affect the facial or ocular muscles as they do in myasthenia gravis. The proximal muscles are weak, but only a quarter have pain and tenderness. Dysphagia occurs from the involvement of the striated muscles of the pharynx, making it difficult to initiate swallowing. How will these patients present to you? Well, first, dermatomyositis presents with a malar involvement. They will have the shawl sign, which is erythema of the face, neck, shoulders, upper chest, and back. It looks like they're wearing a red shawl. They will have a heliotrope rash. Remember that key word, heliotrope. This is edema and purplish discoloration of the eyelids. They're not wearing makeup. Lastly, they'll have Gottron papules, which are scaly patches over the back of the hands, particularly of the PIP and MCP joints. Here's a patient who actually has the shawl sign. Notice the erythema continuous from the face over the shoulders and around the back and chest. Here's an example of a heliotrope rash. Notice the edema and purplish discoloration of the eyelids. And here are the classic Gottron papules. Notice the scaly patches over the back of the hands. Now, dermatomyositis has a very high incidence and co-occurrence of cancer. These cancers most commonly are seen in the ovary, lung, GI tract, and as lymphoma. The best initial test is a CPK and aldolase level. Remember, these enzymes are going to leak if your muscles are breaking down. The most accurate test? Muscle biopsy. If you get an ANA, it will frequently be positive, but remember, this is nonspecific. An anti-JO antibody can be done if the patient has some lung involvement. It's very specific for lung fibrosis, in fact. MRI will detect patchy muscle involvement, and an electromyography will be abnormal. Other labs to keep in mind that are occasionally abnormal are the ESR, C-reactive protein, and rheumatoid factor. Like the occasional presence of anemia, none of these tests are going to help establish the diagnosis. Since this is an inflammatory condition, steroids are usually sufficient for treatment. When the patient is unresponsive or intolerant to steroids, you can use methotrexate, azathioprine, IVIG, or mycophenolate. You can also try hydroxychloroquine if they have significant skin lesions.